Here's a $40 4-hour class you're about to get in 40 seconds. All right, I'm going to check pulse and respirations on the patient. Patient does not have a pulse. There is no breathing present. Peyton, I want you to call 911. Griffin, I want you to go run and grab an AED. You're going to begin compressions at 100 to 120 beats per minute on the center of your chest.
Send help.
You will continue compressions until the patient is either resuscitated or you have an AED. So I'm going to be talking about epinephrine use in out-of-hospital cardiac arrests today. Out-of-hospital cardiac arrests and cardiac disease in and of itself kills approximately 1 in 4 Americans every single year. It is the leading cause of death in the United States, and sudden cardiac arrest accounts for 350,000 deaths a year. Obviously, this problem is prevalent, and if you take nothing else away from my presentation, I want you to take away that adequate and good, quick CPR along with AED use are the best things that you can use to save somebody's life in an out-of-hospital cardiac arrest scenario. Obviously, these things are not exactly fun to talk about. People in the audience may have known a family member or somebody who has died from an out-of-hospital cardiac arrest, and this can be very challenging. And so it's at the reason that my talk is on this is because the importance of cardiac arrest advancements in our out-of-hospital cardiac care today. So right now, just to kind of jump right into it, epinephrine is used typically only by advanced life support providers in the field. What they have the ability to do is to push epinephrine as well as other adrenaline-based drugs to help speed the heart up, and we'll talk about that here in 1 second, as well as use advanced airway devices to create a more patent airway. This is important to understand because it is a small portion of the number of people who are experiencing cardiac arrest that actually get this kind of treatment, because there has to be a paramedic present, and that always is not the case. We're focusing on out-of-hospital because in-hospital, the time to administration of epinephrine and start of CPR by medical professionals is approximately 3 minutes. In the field, it's 21 minutes, and so it's more important for us to understand some of the things behind epinephrine use and why it is used. Epinephrine use research started in dogs in the 1960s. They would induce cardiac arrest in dogs and try to figure out different combinations of pharmacological drugs to give to these dogs in order to bring them back from cardiac arrest. Epinephrine was introduced because it has a vasoconstricting factor to it, as well as a bronchodilator aspect to it. So increased oxygen perfusion and higher arterial pressures was the thought behind epinephrine. It's able to push blood more effectively and more rapidly through the circulatory system of the human, thus allowing them to be more perfused with oxygen. Obviously, this is important when you're doing CPR. You can't maintain adequate perfusion sometimes, and so epinephrine allows you to maintain that perfusion and get good blood flow all the way into the peripheries of your body. However, this isn't always true. There are also additional things that exist with epinephrine administration in patients. You can have dysrhythmias that occur because of epinephrine. You can have decreased blood flow to other organs. There's been a significant amount of research that the heart takes up more blood more oxygen during cardiac arrest with epinephrine on board. And so what that means is that the rest of your organs of your body, namely your brain is what we're concerned with, don't receive adequate amounts of oxygen, and therefore you can suffer neurological damage in that scenario. And that is the crux of the issue that we're talking about in this case, is long-term neurological damage from epinephrine use in out-of-hospital cardiac arrests. We know that epinephrine works on patients, and it works to bring patients back by increasing increasing those arterial pressures like we talked about. There has been very limited research on specifically neurological outcomes of these patients in the long term until very recently. This is the most cutting edge piece of research. The study came out in 2018, and the really important things are highlighted in red here to look at. Namely, you can tell up here that nearly three times as many patients survive to hospital admission with epinephrine use versus a placebo in that scenario in the case of an out-of-hospital cardiac arrest. Of those, survival to 3 months hovers about 3% and 2.2% respectively. What we're concerned with is this bottom one, favorable neurological outcomes at 3 months. Of the nearly 4,000 patients that were treated in the epinephrine group and the placebo group, 82 survived with favorable neurological outcomes at 3 months, and 63, 2.1% and 1.6% of people. That in and of itself is not that interesting to us. What is super interesting is this right here, that those patients with epinephrine administration during their out-of-hospital cardiac arrest suffered nearly twice as much severe neurological damage as those patients who did not have epinephrine pushed. What we can take from this is pretty simple, that yes, epinephrine works to bring back circulation to patients, but no, it does not benefit patients long-term with adequate blood flow to their brain, and therefore they have a much higher chance of having severe neurological damage. The solution to this is very complicated, and that's an issue in and of itself. Like I said at the beginning, cardiac arrest, CPR and AED are your two saviors. Nothing else does as good of a job as those two things. But some things that we could be looking into that would be very helpful for research going forward is more placebo-controlled double-blind experiments like the one I just talked about that look specifically at the issues that I mentioned in the hand, as well as messing with dosages, messing with the timing of the administration of the drug in and of itself, as well as focusing on different drugs that maybe promote microvascular flow versus macrovascular flow, which is what epinephrine does. Or even pushing beta blockers prior to epinephrine administration has been proven and shown to possibly cut down on those dysrhythmias and the possibility of going back into cardiac arrest. If you take one thing from this presentation, like I said, push hard, push fast. CPR is the best possible thing, 100 to 120 beats per minute, or the song Staying Alive. Thank you very much.